Welcome to Advanced Practice, where we brew together the latest thinking in mental health practice. Sleep medicine did not begin as a specialty. It emerged quietly from neurology, psychiatry, and physiology long before clinicians treated sleep as something worth targeting directly. Today, we are launching a series on sleep and mental health. This content is for educational purposes only and does not constitute medical advice, diagnosis, or a prescription. Clinical decisions should be based on individual patient assessment and established professional guidelines. Before sleep medicine had a name, people were already trying to manage sleep the only way they knew how, through environment, ritual, and routine. In the cave age, sleep meant darkness. People slept in caves, wrapped in animal skins, with no artificial light and no choice but to follow the sun. It worked not because they understood hormones, but because total darkness naturally boosted melatonin. Lights out was literal. In ancient Egypt, sleep took on a spiritual frame. Dream incubation was common. People slept on sacred beds in temples, believing the gods would send healing or prophetic dreams. The mechanism was not divine intervention. It was psychology. Ritual lowered stress, created expectation, and calmed the nervous system enough to improve sleep. Traditional Chinese medicine approached sleep through balance. Herbal mixtures like sour jujube seed, cassia seed, and acarus were used for restlessness and insomnia. Some of these herbs containing mildly sedating compounds, but the larger effect came from consistency. A prescribed nighttime routine mattered as much as the ingredients themselves. Greek and Roman physicians moved closer to what we now call sleep hygiene. Hippocrates advised regular meals, physical activity, and avoiding heavy wine before bed. This was an early recognition that lifestyle influences circadian rhythm, even if the biology was not yet understood. That's where this series begins. In the episodes ahead, we will break down pharmacologic treatments, what they actually do to the sleep-wake system, and later we will walk through a clinician-ready introduction to cognitive behavioral therapy for insomnia, or CBT-I. But before we talk about treatment, we need to understand how sleep medicine came into being. For most of history, sleep was misunderstood. Ancient physicians believed sleep was passive, the brain simply shutting down. Insomnia was not a disorder. It was personality, stress, or moral weakness. Psychiatry inherited that model. Poor sleep was framed as a symptom of anxiety or depression, not a condition in its own right. That assumption began to crack in the early 20th century. In the 1920s, the first human EEG recording showed something unexpected. The sleeping brain was not inactive. It was organized. By the 1930s and 40s, distinct brainwave patterns were identified. Sleep had structure, stages, architecture. The inflection point came in the 1950s with the discovery of REM sleep and its link to dreaming. During REM, the brain is emotionally active, cognitively intense, and neurobiologically awake. Researchers soon mapped predictable cycles of REM and non-REM sleep across the night. Sleep became measurable, repeatable, and pathological when disrupted. At the same time, clinicians noticed something else. Some patients were not just tired. They were emotionally dysregulated, cognitively slowed, and functionally impaired. In the 1960s, obstructive sleep apnea was formally described. Patients were repeatedly suffocating during sleep and often without awareness. Depression, irritability, and poor concentration were not primary psychiatric disorders. They were downstream effects of untreated sleep pathology. Narcolepsy was reclassified as a neurologic disorder of sleep-wake regulation rather than laziness or hysteria. Parasomnias were separated from psychosis. By the 1970s, sleep laboratories and polysomnography made it possible to study sleep in real time. In 1975, the first formal classification of sleep disorders gave the field a shared language and a clinical identity. The 1980s and 90s expanded the impact. CPAP transformed sleep apnea from fatal to treatable. Cognitive behavioral therapy for insomnia emerged as an evidence-based intervention. Circadian rhythm disorders were reframed as biologic misalignment, not poor discipline. For psychiatry, the implications were clear. Insomnia was not just a symptom. It was a risk factor, a predictor of depression, anxiety, substance use, suicidality, and cognitive decline. In the 2000s, neuroscience accelerated everything. The discovery of orexin explained narcolepsy at the molecular level and reframed wakefulness as an actively maintained state. Today, sleep medicine sits at the center of psychiatric care. Chronic insomnia is recognized as an independent disorder with first-line behavioral treatment. Sleep disruption is understood as a driver of emotional dysregulation and treatment resistance across diagnoses. That is the foundation for this series. In the episodes ahead, we will examine sleep medications with precision, what they target, where they help, and where they cause harm. Sleep is no longer the background noise of mental health care. It is the signal. Thanks for listening. If you found this episode useful, share it with colleagues across disciplines. Until next time.